This video is on congenital spinal disorders, and I'm going to concentrate on the adult patient. So we're going to look at a number of disorders. We'll start with skin-covered malformations, then cover the non-skin covered malformations or myelomeningeal, Chiari malformations, Syringomyelia, Basilar invagination, and meningeal cysts. Most talks about congenital disorders start with embryology. I never liked embryology and really never understood it, so I'm not going to cover any of that. So let's start with the skin-covered malformations: lipoma, dermoid and epidermoid, neuroenteric cyst, dorsal dermal sinus, abnormalities, and meningeal. So this is lumbar spine on a child. We can see on this T1 image, T1 bright fat in the spinal canal, and it's contiguous with the subcutaneous fat here. Different patient, again, has a fatty lesion in the spinal canal. And the third one with another lesion that contains fat within the spinal canal at the filum terminale. So all three of these lesions are spinal lipomas. If the bony elements are deficient, then we get the lipomyelocele, lipomyelomeningeal. When the bony elements are intact, we can talk about intradural lipomas and lipoma of the filum terminale. So lipomyelocele, lipomyelomeningeal, this is a lipoma that's attached to the dorsal surface of an incompletely closed spinal cord, also called a neural placode. So here's the spinal cord, and the dorsal surface of the cord has the lipoma attached to it. The lipoma here is contiguous through the bony defect with the subcutaneous fat. So the subcutaneous fat is contiguous with the spinal lipoma through the bony defect in the spinal canal. This is covered by skin and almost always associated with a tethered cord. The treatment of this is untethering. So the surgeon cuts through the lipoma and filum, resects as much of the lipoma as possible so that the cord becomes untethered. Intradural lipoma is most frequent in the thoracic spine. So this is a subpial lipoma. It invaginates into the cord. These cases, the bony elements are intact. Here's a T1 showing the high signal intensity lipoma. This is a fat suppressed T2 showing it dark signal. Another intraspinal lipoma. This one, actually the bony elements are not present, and that's because the patient had surgery. This was partially resected. The lipomas do grow over time. They can get larger, especially if the person gains weight. The lipoma tends to grow as well. Lipoma of the filum terminale, most of the time is an incidental finding, but occasionally can be associated with tethered cord. So if you see it, you need to at least think about, could there be a tethered cord? So what is a tethered cord? So in tethering, there's traction on the conus. It stretches the cord, constricts the blood vessels, causing chronic ischemic change in the cord. The patients present with bladder dysfunction, stool incontinence, leg weakness, decreased sensation. They gradually progress over time. Sometimes they're not, don't become noticeable until adulthood. So how do we decide if the cord is tethered? The easiest thing is to look at the location of the conus. The conus normally should be above L2-3. So if the conus ends at the level of the L2-3 disc or below, most of the time it will be associated with clinical signs of tethered cord. Often, but not always, there'll be an associated lipoma, and the phylum is often thickened. So if the phylum is greater than or equal to 2 millimeters thick at the L5S1 level, that usually indicates a tethered cord. So this is a patient with lipoma and a tethered cord. The conus is way down low, L3 or L3-4. This is a patient with a lipoma of the phylum terminale, and although most of the time these are not associated with tethered cord, this patient did have symptoms of tethering, even though the conus was only at about, was just above L2-3 in this case. So occasionally they can have symptoms of tethering even if the conus is above L2-3, but most of the time, most of the patients who are symptomatic, the conus is going to be below L2-3. This is just to show how you would measure the thickness of the phylum, and this is at L5S1, and here it measures more than 2 millimeters. Okay, this patient has a lesion in the lumbosacral spinal canal. It's bright on T2, dark on T1, does not enhance with contrast. See the lesion expands the spinal canal here. So this is an epidermoid cyst. We'll put dermoid and epidermoid together. The epidermoids can be congenital or acquired, mostly congenital. You can get an acquired epidermoid cyst by pushing skin into the subarachnoid space. This happened occasionally before people started using styleted needles for lumbar puncture. So the purpose of the styleted needle for lumbar puncture is so that you don't push any skin into the spinal canal, which could potentially cause an epidermoid cyst. So these lesions, dermoid and epidermoid, are usually extramedullary. Occasionally they can be intramedullary. The epidermoid cysts usually have signals similar to CSF, although they're very bright on diffusion, and the dermoids often contain fat. No enhancement. About a quarter of these are associated with the dorsal dermal sinus, and there's a risk of rupture into the CSF causing a chemical meningitis. Here's a lesion in front of the upper cervical cord. It's slightly bright on T1, very bright here on T2. Looks like it's at least partially encircling the left vertebral artery. Again, here's T1. The lesion, it's a little hard to see. It's over here. I guess it's in this case it's isointense to spinal cord. Here it is on a post-contrast T1, no enhancement. And on a diffusion-weighted image, again, you can't really see it too well, but the lesion is over here. It has increased diffusion, so no restriction, increased diffusion. And this is a neuroenteric cyst. So these are typically is intradural extramedullary mass, anterior to the brainstem, cervical or thoracic spinal cord. Classically, it's bright on T1 and bright on T2. There occasionally have bony anomalies, only about 40%, and the anomalies can be either anterior or posterior. This is a CT myelogram, and you can faintly see a linear density going from the skin to the muscle here at L3-4. And when we look at the thecal sac has a little pointed appearance at L3-4, and inside the thecal sac we see this low density fatty lesion attached to the spinal cord. Here's this lipoma attached to the spinal cord, and here you can see where the thecal sac has this pointed appearance at L3-4. And this is a patient with a dorsal dermal sinus. So dorsal dermal sinus is a sinus tract that extends from the skin into the spinal canal. About half of the time, these terminate in a dermoid or epidermoid cyst, and about 20% of the time that they're associated with a lipoma, like in this case. These are usually in the lumbosacral region, and they're usually associated with a tethered cord and a low conus. There is some risk of meningitis because of the communication between the skin and the subarachnoid space. Now, clinically, a sacral dimple and dorsal dermal sinus look very similar. Most of the sacral dimples are lower down in the sacrococcygeal region, whereas the dorsal dermal sinus is usually higher up in the lumbar or lumbosacral region. This T2-weighted MR, the sagittal image shows the conus is low-lying. On the axials, we see two spinal cords. Here it is on T1. And this is a patient with diastematomyelia. Most of these are female. Often there's a hairy patch or nevus on the back. They clinically present with weakness, diminished sensation, incontinence, scoliosis. Half the time there are two separate dural tubes, and they're separated by a bony or cartilaginous spur. Half the time there's a single dural tube without a bony spur. These tend to present later on, often in adulthood, and they have much less severe symptoms. There's often a syrinx above the split and a thickened phylum below the split. This is a patient with diastematomyelia with two dural sacs with a bony spur separating the two dural sacs. And the patients don't have an open defect, but frequently there's a anomaly involving the lamina in the spine of the patients with diastematomyelia. CT shows this water density lesion widening the spinal canal and extending anteriorly. Here it is on MR. Here's the T2 bright lesion and extending anteriorly here. Sagittal image, you can see the lesion widening the spinal canal and then extending into the presacral region. And this is a meningeal. So a meningeal is a diverticulum of the thecal sac that protrudes outside the spinal canal through one or multiple widened neural foramina. These can be sporadic, or they can be associated with either Marfan's or NF1. So the sacral meningeals are anterior. They have a thin stalk, and they present as a retrorectal mass. The lumbar or thoracic meningeals are lateral because they go out through the neural foramina. Of the thoracic meningeals, the vast majority are associated with NF1. So let's now move to the non-skin covered malformations, the myelomeningocele and the Chiari malformations. This is a fetal MRI, and we can see a defect in the lower spine with fluid protruding out. You can also see a abnormality of the posterior fossa here. This is the baby shortly after birth, showing this open defect, this myelomeningocele. So we don't see this as frequently since folate supplementation has become routine. These are obvious at birth, so we do not image the myelomeningoceles immediately. These are usually repaired right after birth. So if we image them, it's usually not until after they're repaired. As in this case, we can see this is a patient who had a repaired myelomeningocele, so it's no longer, now it's covered by skin. This is T1 weighted MR. Part of the cerebellum is herniating down into the spinal canal. This is named after Hans Chiari. This is the Chiari 2 malformation. The Chiari 2 malformation is secondary to a myelomeningocele, so this is only seen in patients with myelomeningocele. The cerebellar vermis here and the fourth ventricle herniate through the foramen magnum. So these are always seen with a myelomeningocele, and it's thought that the low CSF pressure due to the CSF leaking out through the open defect causes the hindbrain to herniate through the foramen magnum. We also see some associated intracranial findings. Frequently they have a beaked appearance of the tectum here. You can see it comes to a nice beak. Large massa intermedia. Incompletely formed corpus callosum. And these other things may or may not always be present. This is a myelogram in a patient with a Chiari 2 malformation. You can see the characteristic appearance of the fourth ventricle. It has a very narrow AP dimension with the cerebellar vermis extending through the foramen magnum. Lower down, you can see the remnant of the repaired myelomeningocele. This is a different patient with the cerebellar tonsils extending through the foramen magnum. This patient does not have a myelomeningocele. This is a Chiari 1 malformation. In a Chiari 1 malformation, the tonsils extend at least 5 millimeters below foramen magnum. They typically have a pointed appearance, and there's not enough space. Usually we see this relatively tight appearance at the foramen magnum. Often associated with syrinx. Also, it's frequently associated with skull base and craniovertebral junction anomalies. The patients often have occipital headache, cerebellar ataxia, vertigo, lower cranial nerve palsies. The headache classically worsens with a valsalva, coughing, or change in position. So just to compare Chiari 1 malformation, cerebellar tonsils extend below foramen magnum, normal fourth ventricle. With a Chiari 2, where it's the cerebellar vermis, as well as the tonsils, and this abnormal appearance of the fourth ventricle. You can also see the Chiari 1 malformation on CT. This is on axial. You can see things look tight around foramen magnum with the cerebellar tonsils low. On the sagittal image, you can see it a little bit better with the cerebellar tonsils extending well below the foramen magnum. This is just to show how you would measure the distance. If you measure it, always measure from the bottom of the black cortical bone. So draw a line between the anterior and posterior foramen magnum, right at the edge of the black cortical bone. A lot of these patients will have a syrinx. Most of the time the syrinx goes all the way up to the cervical spine, but sometimes you'll only see the syrinx lower down in the thoracic spine. This is a young child with a Chiari 1 malformation here, a little syrinx, and most of the time these don't change that quickly, but this patient not long after had a follow-up and the syrinx had gotten quite a lot larger. So occasionally these can enlarge significantly, especially in children. One thing that you don't want to confuse a Chiari 1 malformation with is this situation. Here it looks like there's a Chiari 1. The cerebellar tonsils are down below foramen magnum. Things are tight. There's syrinx and edema within the spinal cord. But this patient has diffuse dural enhancement here. So diffuse dural or pachymeningeal enhancement. This is a patient with CSF leak and intracranial hypotension. After the CSF leak was treated, this is a follow-up, and the apparent Chiari 1 malformation has resolved, and the syrinx and the pachymeningeal enhancement have also resolved. So this was a patient with intracranial hypotension that had some people call it a pseudo-Chiari or acquired Chiari malformation. We occasionally will use CSF flow gated cine phase contrast images to evaluate patients. So I'm just going to show what a normal looks like, and the CSF anterior and posterior to the spinal cord should be the same signal. So these in these studies, the CSF flow is gated, so we see flow throughout the cardiac cycle throughout the cardiac cycle, and it should be uniform, relatively uniform all around the cord. So on these studies, black is flow one direction, white is flow the other direction. The various scanners can code the flow up or down as black or white. Doesn't matter that much, but one direction is black, the other direction is white. And in a normal patient, the flow is uniform all around the spinal cord. In the patients with the Chiari 1 malformation, the flow tends to be different in front and behind the cord, so it may be in somewhat different phases in front and behind. Let's look at a patient with a Chiari 1, and the flow behind and front of the cord are not uniform, so we may see a lot of flow in front and not as much flow in back, or maybe going upward in front while it's still going downward in the back. And I'll just show a comparison with a normal on the left, Chiari 1 on the right. So it's not clear how useful these are. We do them occasionally. I don't think it's not very reliable in terms of predicting whether patients will improve after surgery, but we do it from time to time. So treatment of Chiari 1 malformation, suboccipital craniectomy, which may or may not be associated with the duroplasty. Often with that treatment, the syrinx will often get smaller or resolve. So I'm going to talk a little bit about Syringomyelia. Has a number of different names. They're all pretty much the same: syrinx, hydromyelia, hydrosyringomyelia. Most people use these interchangeably. There's a fluid-filled cavity in the spinal cord. The fluid is isointense to CSF. Clinically, the patients may have decreased sensation, paresthesias, especially in the shoulders, neuropathic joints, weakness and hyperreflexia, abnormal gait, and often have scoliosis. Many different things can cause syringomyelia. We talked about Chiari 1 malformation. Other deformities of the craniocervical junction can also cause it. It's associated with occult spinal dysraphisms. Some we talked about: dorsal dermal sinus, lipomyelomeningocele, diastematomyelia, tethered cord. It's also associated with spinal cord tumors, late complication of trauma, and arachnoiditis and arachnoid web. Even with all these potential causes, many of them, if not the majority, we never find any cause, and we just label them as idiopathic. So this patient has a large syrinx. If we look carefully, there's an enhancing tumor at the upper part of it. Another patient with a extensive syrinx, and the main reason we do post-contrast images in patients with syrinx is to make sure we don't miss an associated tumor. In this case, the patient had a small hemangioblastoma causing the syrinx. So to treat it, you treat the causative process. So if it's a Chiari 1, suboccipital craniectomy. If it's a tumor, you resect the tumor. Occasionally, the syrinx can be drained into the subarachnoid space or peritoneal space with a shunt catheter. Often these get clogged up, so they don't work all that well. Basilar invagination. So here's a sagittal T1 and axial T2 weighted image. We can see the skull base here sticking into the spinal cord. You can see here it is on the axials, and this is a patient with the basilar invagination. You may also hear the term basilar impression. Some people separate basilar invagination and basilar impression for either one representing congenital and the other representing acquired. I don't really think that's helpful. Most people just lump it all together and just use the term basilar invagination. So what it is, it's a deformity of the skull base that causes the compromise of the brain stem. So most of the time it's congenital. The acquired forms are due to Paget's, osteomalacia, or rheumatoid arthritis. The rheumatoid arthritis patients, some people use the term cranial settling. Basilar invagination is often associated with Chiari 1 malformation. Clinically, the patients have a headache, occipital headache, neck pain. Flexion and extension of the neck often makes the symptoms worse. They may also have cranial nerve dysfunctions, dysarthria, vertigo, and myelopathy. In the plain film days, we used to draw lines. We can still draw lines. They're not as useful anymore. But the The one that's most frequently used is Chamberlain's line. Chamberlain's line is a line between the posterior margin of the hard palate and the posterior lip of foramen magnum. Normally, the odontoid process is below Chamberlain's line, or just minimally above it. If the odontoid process is goes significantly above Chamberlain's line, here it is here, then generally the patient has basilar invagination. On plain films, sometimes some people preferred using McGregor's line over Chamberlain's line. The only difference is that McGregor's line is from the posterior hard palate to the lowermost point of the occipital skull. This was a little bit easier to draw because sometimes it was hard to see exactly where the posterior lip of the foramen magnum was, but they both were used. The McGregor's line was typically slightly below Chamberlain's line. McGregor's line is almost impossible to draw on an MRI, so if you're using a CT or MRI, you can use the Chamberlain's line, but not usually the McGregor's line. In general, these lines are not necessary on CT or MR because you can actually see the skull base poking into the spinal cord. Another term you should know about is platybasia. Platybasia is present when the basal angle or Welcher basal angle, which is an angle between the nasion, tuberculum sella, so nasion, tuberculum sella, and basion. That's the tip of the foramen. That's the anterior tip of the foramen magnum. If that angle is more than 140 degrees, then we call it platybasia. And most of the time, if there's platybasia, the patient will have basilar invagination. This may not be that obvious here, but these two vertebrae are fused. So this patient has fusion of cervical vertebrae and maybe down here as well. So this is a clipple file, which is congenital fusion of two or more cervical vertebrae. Most often fused are C2-3 and second most common C5-6. This is often associated with Chiari 1 malformation, as it is in this case here. Often associated with basilar invagination, assimilation or fusion of C1 into the occiput. It can also be associated with diastematomyelia and Springel's deformity. So basilar invagination, the treatment, suboccipital craniectomy, posterior occipitocervical fusion. Sometimes they will resect the dens or clivus, either transoral or endoscopic transnasal approach. The final topic will be meningeal cysts. So here's a CT myelogram. We see a cyst in the sacral region. We see these fairly commonly. So this is an extradural meningeal or arachnoid cyst or diverticulum. A lot of different terms used for these. These are diverticula of the thecal sac or nerve root sleeves. There's usually some congenital deficiency of the dura. The cysts are lined by arachnoids, so you can call them arachnoid cysts. They have a narrow connection to the thecal sac. Sometimes associated with elevated CSF pressure or intracranial hypertension. Sometimes if the pressure is high, that can cause these cysts to get larger. This is on a myelogram. We see one of these cysts. We typically will call this a Tarlov cyst. The Tarlov cyst term is used if the cyst is associated with a nerve root sleeve. So these are extradural arachnoid cysts. If it's associated with a nerve root sleeve, you use the term Tarlov cyst. They're generally asymptomatic. Rarely they can cause pain but usually this is just an incidental finding. The cysts can occasionally rupture and cause intracranial hypotension. So another patient with a Tarlov cyst associated with a root sleeve. The most common in the lumbar, in the sacral region, but you can see them anywhere in the thoracic or in the cervical region. So they can occur anywhere. There's another patient with an extradural arachnoid cyst. This is not a Tarlov cyst. It's a different variety of extradural arachnoid cysts. These are congenital. You'll see these occasionally. They're generally incidental findings. There's another patient with a cyst here. This is a little bit different. This one is an intradural arachnoid cyst. So these intradural arachnoid cysts can be congenital or can be secondary to an arachnoiditis or meningitis. They're most often in the thoracic spine, and they can compress the spinal cord. You don't always see the walls of the cyst as nicely as you do in this one, but sometimes it's very hard to see those walls. They're very thin. The differential diagnosis of this intradural arachnoid cyst is spinal cord herniation and dorsal arachnoid web. This patient, the spinal cord has a somewhat funny shape here. There's a syrinx in the cord, and this appearance has been likened to the appearance of a number 15 scalpel blade. And it could be a scalpel. Sometimes it's the scalpel blade pointing up, sometimes it's pointing down. In this case, it's pointing up, but it can be the other way as well. This is the typical appearance of a dorsal arachnoid web. So the thoracic cord, they're generally thoracic, is displaced anteriorly by the web, and it's often associated with cord edema and or syrinx. And the cord edema or syrinx can either be below the web or above the web. So in this case, it's below the web, but in other cases, it's above. It can be above also. And the important thing here is recognizing that scalpel sign, which is virtually diagnostic of the dorsal arachnoid web. And finally, the lesion that can look similar to either arachnoid cyst or dorsal arachnoid web is transdural spinal cord herniation. And you can see here the spinal cord is displaced anteriorly, and a knuckle of spinal cord has herniated through the dura, causing this appearance. And instead of the scalpel sign, the spinal cord usually has a C-shaped appearance here. So this is more of a C shape as opposed to the scalpel sign that you see with a dorsal arachnoid web. Thanks for your attention.